All right, good morning and welcome to Quick Take Charge. I'm Jennifer Zabasaja in New York. We are starting off today with By the Numbers, of course, where we give you the data that tells the story. This morning's number is 1 million. What we're saying is there's no sign the pandemic is slowing. For the second day in a row, the number of coronavirus cases around the world went over 1 million. But there's more evidence that the Omicron variant leads to milder symptoms than other strains of the coronavirus. The U.S. surge appears to be triggering a lower rate of hospitalizations than earlier waves. The number of people hospitalized hit a 7-day average of just under 9,000. That's half the peak that was recorded last January. So we're going to dig into all of these developments with Dr. Amish Adalja. He is a senior scholar at the Johns Hopkins Bloomberg Center for Health Security. Dr. Adalja, thanks so much for being here. Welcome back to Quick Take as always. First of all, I wanted to start with this news that we got yesterday from the FDA about rapid tests. For a lot of people who have been traveling over the holidays, they were resorting to buying rapid tests and taking them before they resume their normal operations. But the FDA is saying that these tests may not even be able to spot Omicron. How should we interpret this news? How are you interpreting it?
Well, it all depends upon what you're asking a test to do. What question is the test going to answer for you? If you're an asymptomatic person who just wants to know, am I safe to be around others? Those rapid antigen tests serve a really good function because they're able to detect when you have enough virus to infect somebody else, especially when they're done in a serial fashion, meaning day 1, day 2. You do them on a regular interval. We know that those work that way. But if you are sick, if you've got symptoms and the test is negative, you're asking a different question. You're not asking, am I safe to be around? You're asking, what am I sick with? And in those situations, if a rapid test is negative, you may need more evaluation with either a PCR test, a formal rapid antigen test, or maybe this is influenza, or maybe this is strep throat or RSV. So in those situations, you shouldn't just stop at a test. That's how I use these tests. That's how I recommend them to be used. They really have to be focused on the context of why someone is getting tested.
Do you see, a lot of people have had a lot of concern and issues getting PCR tests. We've seen lines down the street here in New York City and elsewhere. So then how do we alleviate some of that, right? If we're not doing rapid antigen tests at home, what is it that we need to see to ramp up the availability of PCR tests for people?
Well, there are some molecular tests that are available over the counter that can be done at home in a kind of a proctored fashion with telemedicine. So those exist as well. But we really have to get better at testing and make this a keystone of the pandemic response. Vaccines were the most important thing that we had, but we can't completely rely on vaccines, especially in the face of a variant like Omicron, which can get around some of that vaccine-induced immunity. And as people are now ready to try and navigate a world with COVID, they need to be able to know their status quickly. So we really have to just prioritize testing in a way that it's never really been since the very beginning of this pandemic. The United States has always lagged behind pandemic in the pandemic when it comes to testing. And I've always said it's sort of the original sin of this pandemic, and it continues to be so. But it really requires a full forced effort to make sure that labs have capacity, that they have reagents to do PCR, that we have more home tests, not just antigen tests, but maybe even the molecular ones, so that everybody has everything at their fingertips. That's how we come up with a way to be resilient in a world where COVID-19 is going to be ever present.
Yeah, and Dr. Adalja, we mentioned this at the top of the show, 1 million cases for 2 days in a row. A lot of people, though, anecdotally, just from some of my friends, people are getting Omicron or supposedly getting sick with COVID, not getting as severe of an illness. What are you seeing in the hospital? Are you still getting really severe patients, and how are you treating them? What are the things that are happening behind the scenes?
Well, we are still seeing severe patients, but this is not a systemic issue. It's more regional, depending upon the vaccination status of the population. And remember also that even though we hear lots about Omicron, there's still a lot of Delta in the hospital, and Delta still comprises a significant percentage of cases, and Delta does cause a lot more severe disease. So when you see Omicron, I think it all depends upon who's getting infected. If these are fully vaccinated people, and many of whom have got booster vaccines in New York City, you're going to see everything skewed towards the mild side, because in a vaccinated person, COVID caused by Omicron or caused by Delta tends to be very mild as long as they don't have any underlying conditions. It's when Omicron infects high-risk individuals who have no vaccination, like the person who had reportedly died in Texas from Omicron. Those are the types of people we're worried about, is if they have a high rate of hospitalization and if they cause hospitals that are already still working on Delta patients that have been there for some time or that are still getting infected with Delta, if that's enough to push them over the edge. So it's not about healthy vaccinated people with Omicron. That's a totally different track. It's unvaccinated high risk people that we worry about.
And we were talking earlier just about what is happening in the hospitals and in terms of those who are more severe. You were speaking specifically about antibody treatments and sort of how that has differed. It's always a different story, I feel like, every day with COVID. But how are you treating patients that are coming in and potentially aren't vaccinated?
Usually, so it depends first on if they need to be hospitalized. If they have to be hospitalized, they're going to get the standard oxygen, dexamethasone, remdesivir, and certain immune modulating drugs if they get severely ill. If someone doesn't need to be hospitalized, you try to hook them up with monoclonal antibody treatment. Paxlovid, the oral Pfizer antiviral, is approved in the United States, but it's not widely available yet, so it's not something people are using routinely. But we try to get the monoclonal antibodies. And the problem is that if you're in a place where Omicron is dominant, 2 of the 3 monoclonal antibodies will not work, and only 1 does work. So that people have shifted onto which monoclonal antibodies they can use because of that change in the variant specificity. And early on, we thought that Omicron was 73% of cases, but it turned out to be 23% of cases. So I wonder if any patients were harmed because monoclonal antibody treatments were shuffled or halted because people assumed they were dealing with Omicron when they were dealing with Delta. And I think that's something that needs to be investigated a little further.
How concerned are you, Dr. Adalja, about more variants in the new year? I mean, I know you've said that we eventually need to get used to living with COVID, but is this potentially going to get worse in January when it's winter season, of course, and as you mentioned, flu and other things that are circulating around?
I do think January is going to be a rough month. I don't think it's going to magically get better all of a sudden. We're still kind of rising with Omicron. It now represents around 60% of cases. We expect it to go up to 100% or so. And that peak sometimes happens quickly with Omicron versus other variants. So I think we'll know more only after we get through January and look back in hindsight. But we have to anticipate that we're going to see cases continue to increase. That's always going to be the issue. The key has to be hospital capacity and working on trying to keep people out of the hospital with tools like monoclonal antibodies and tools like Paxlovid, which we didn't have. So even though we talk about how it's going to get worse, it's bad, this is still not last year. This is nowhere near last year in terms of what was going on in the hospitals and the lack of tools and understanding we had. So I think there is reason for optimism, but yes, this is going to still be a COVID winter.
Well, so then what should people think about when assessing whether they have New Year's Eve plans? We've seen some cities cancel them entirely. Here in New York City, I think they're doing a scaled back version in Times Square. Should people avoid getting together in big groups entirely, or what's your assessment of it?
This goes back to the 2-track pandemic we're on. If you're somebody who's fully vaccinated, I think you can go about your New Year's plans as you want. Just know that you can't get the risk down to 0, especially with the variant like Omicron. But if you do get your inevitable breakthrough infection, and everyone, I believe, is going to get infected with Omicron at some point, it's going to be mild, and that's a victory. And it's something that you can navigate. It's a manageable risk. If you're unvaccinated, particularly if you're at high risk, Omicron poses a major threat to you. And this is where it's important to test. It's important to think about masks, all of that, because you still are at risk for severe disease. That's what the president sort of articulated in his speech, that we're on kind of a 2-track pandemic for the vaccinated and the unvaccinated. And I think that's the way we're going to proceed for some period of time.
Absolutely. And he's continuing to push people to get vaccinated, of course. Dr. Amish Adalja, senior scholar at the Johns Hopkins Bloomberg School of Public Health. Thank you so much, Dr. Adalja. Great to talk to you. And we should note the Johns Hopkins Bloomberg School of Public Health is supported by Michael R. Bloomberg, founder of Bloomberg LP and Bloomberg Philanthropies.